Hello everyone, welcome to the channel. Today we're tackling a really important and often misunderstood condition, acute pancreatitis. This is a serious condition with various complications and very frequently encountered among the general population. Let's jump right in with a compelling case study that perfectly illustrates what we're talking about. So, meet John, a 52-year-old construction worker. He loved his fatty meals. He had a history of dyslipidemia, fatty liver disease, high blood pressure, and grade 2 obesity. He has no family record of known cancers or other significant diseases, no allergies, and in terms of medication, he only takes 20 milligrams per day of atorvastatin and 10 milligrams per day of amlodipine. One day, out of nowhere, he was hit with an excruciating sharp pain in his upper middle abdomen. The pain rapidly worsened, shooting straight through to his back, making every position unbearable. Within hours, intense nausea and multiple episodes of vomiting are associated with the pain. Alarmed, his wife immediately called an ambulance. When John arrived at the emergency department, his vitals showed high blood pressure, 150 over 87 millimeters of mercury, but his heart rate 88 beats per minute and oxygen saturation 99% were normal, with no signs of breathing difficulty. A quick physical exam revealed a very tender upper middle abdominal area, though without the rigid muscle guarding. His urination and bowel movements seemed normal. So with John in the ER, what did the doctors do next? They ran some tests, of course, and this is where things really started to point towards our diagnosis. First, the serum lipase results came back, and this was a major red flag. It was significantly elevated at 1,200 units per liter, which is more than 3 times the upper limit. Then his complete blood count showed an elevated white blood cell count, or leukocytosis, a clear sign of inflammation, especially if it is associated with an elevated C-reactive protein, or CRP. And we also saw his liver function tests were mildly abnormal, hinting at a potential issue with his bile ducts. Now, after those lab results, the doctors needed to see what was happening inside John's body. And this is where imaging really solidified the picture. An abdominal ultrasound was performed first, and it revealed multiple gallstones in his gallbladder. But crucially, a small stone was also spotted right near the common bile duct, strongly suggesting that gallstone obstruction was the root cause of John's pancreatitis. To get a definitive look, to really confirm things, John had a contrast-enhanced abdominal CT scan. This scan clearly showed diffuse enlargement and swelling, or edema, of the pancreas itself, surrounded by significant parapancreatic fat stranding, a telltale sign of widespread inflammation. Small fluid collections were visible around the pancreas, consistent with acute inflammatory exudates. But most importantly, the CT also confirmed multiple gallstones within the gallbladder and an associated common bile duct dilation, unequivocally pointing to a biliary origin for his pancreatitis. The CT showed no evidence of pancreatic necrosis. This indicated an interstitial edematous form rather than the more severe necrotizing variant. Therefore, John was diagnosed with a mild form of acute biliary pancreatitis. So that's John's story. Now let's talk about the condition itself. What exactly is the acute pancreatitis? I won't dive too deep into the nitty-gritty anatomy and physiology, but here's what you absolutely need to know. The pancreas is a vital digestive gland with a dual function, endocrine and exocrine. Today our focus is on problems with its exocrine function. Here's how its exocrine function works. Pancreatic juices are absolutely critical for food digestion. You see, amylase helps digest carbohydrates by breaking down complex carbs, like starch, into simpler sugars. Then lipase is all about fat digestion. It teams up with bile to break down triglycerides into fatty acids and glycerol. And finally, trypsin and chymotrypsin, these are secreted in an inactive form. They're released into the small intestine and only become active there, specifically in the presence of protein. This ingenious mechanism prevents the pancreas from autodigesting itself. These powerful enzymes then break down complex proteins into simple molecules called amino acids. Now let's move on to define what actually is acute pancreatitis. Simply put, acute pancreatitis is the sudden and severe inflammation of the pancreas. While there are many ways to classify it, we will not focus on it in this video. What causes acute pancreatitis? Now let's break down the main culprits for this condition. The most common cause of acute pancreatitis is gallstones. Imagine a gallstone forming in the gallbladder, or, less commonly, in the bile ducts. Then it can migrate alongside the duct and it might even get stuck at the ampulla of Vater. That's the point where the main pancreatic duct joins the common bile duct. This blockage can cause pancreatic enzymes to back up and accumulate, which will injure and inflame the pancreatic tissue itself. Next up, a really significant causal factor is alcohol consumption. Whether it's long-term use or a binge drinking episode, alcohol is actually responsible for roughly 25 to 35% of cases. Now, while the exact mechanism isn't fully understood, it's thought that alcohol increases the production of pancreatic enzymes, further promoting that dreaded autodigestion. The third most common cause we see is elevated triglyceride levels in the body. Specifically, medical guidelines point to triglyceride values greater than 1,000 milligrams per deciliter. While triglycerides themselves aren't toxic, their breakdown into harmful fatty acids by pancreatic lipases is the root cause of lipotoxicity in acute pancreatitis. Therefore, the severity of acute pancreatitis in individuals with elevated triglycerides results from a combination of the body's inflammatory response to the pancreatitis and the cellular damage inflicted by the hydrolyzed triglycerides. Interestingly, clinical practice shows that even without other factors like alcohol or gallstones, metabolic issues can trigger pancreatic reactions at lower triglyceride values, sometimes even around 300 milligrams per deciliter. Less frequently, hypercalcemia or high calcium levels in the blood can cause an acute pancreatitis episode. Usually, correcting the underlying problem and normalizing calcium levels resolves these episodes. Of course, in certain specific, though rarer situations, anatomical variations like pancreas.There can be a factor. Here, the two pancreatic ducts open separately. While often asymptomatic, this condition can manifest with repeated episodes of acute pancreatitis. Then we have drug-induced pancreatitis. Certain medications can trigger it, and this includes drugs like glucocorticoids such as prednisone or methylprednisolone, or specific antibiotics like sulfonamides or tetracyclines. Also, immunosuppressants like azathioprine or 6-mercaptopurine, and even some anti-diabetic medications such as GLP-1 agonists can be responsible for an acute pancreatitis episode. Autoimmune pancreatitis is another distinct form, often linked to other autoimmune conditions, for instance, ulcerative colitis, especially the type 2 form, but this is a condition that we will separately talk in another video. And finally, although quite rare, acute pancreatitis can sometimes occur post-procedurally, after an ERCP, endoscopic retrograde cholangiopancreatography, intervention. How does this disease manifest? As a general rule, the most characteristic symptom is a band-like pain located in the upper abdomen, often radiating straight to the back. Sometimes patients describe it as a diffuse abdominal pain without a specific spot at all. It's frequently accompanied by nausea and vomiting, often without food content, or bowel transit disturbances like loose stools. Well, for a diagnosis of acute pancreatitis, at least 2 out of 3 criteria must be met. First, we must have suggestive symptoms, like the pain John experienced. Second, suggestive laboratory tests. That's your elevated lipase or amylase. And third, suggestive imaging. Let's take this diagnosis process step by step. During the initial evaluation, it's absolutely crucial to gather the patient's history. Is this their first episode? What other diseases do they have? What's their family history? What medications are they taking at home? Any alcohol consumption, either greater than 50 grams per day or excessive binge drinking. And very importantly, are there any associated symptoms such as abdominal colic, nausea, or vomiting in their recent past? Next, the biochemical assessment. This will involve evaluating elevated pancreatic enzymes, specifically hyperlipemia or hypermycemia. Generally, these levels should be at least 3 times the upper limit of normal. Studies actually indicate that lipase elevations occur earlier and last longer than amylase elevations, making them particularly useful in patients who present more than 24 hours after pain onset. Pro tip: it's important to remember that serum lipase is also more sensitive than amylase in patients with alcohol-induced pancreatitis. An inflammatory syndrome, evidenced by elevated inflammatory markers like C-reactive protein, is commonly found among the lab results. Depending on the cause of pancreatitis, the patient might also have other altered lab results, such as liver enzymes, total bilirubin level, triglyceride levels, calcium levels, and so forth. Then we move to imaging. As John's case beautifully demonstrates, an abdominal ultrasound can be used to diagnose certain causes, particularly biliary pancreatitis. We'll look for what we call hyperechoic images with posterior acoustic shadowing, which is suggestive of stones in the gallbladder or common bile duct. Other suggestive signs include ductal dilation and periductal edema. Now, the most sensitive method for detecting acute pancreatitis, hands down, is a contrast-enhanced abdominopelvic CT scan. This can reveal changes totally consistent with acute pancreatitis, things like organ enlargement, peripancreatic fluid, fluid collections, areas of necrosis, and more. We'll stop here for now. I know that was a lot of information to take in, but I really hope you found it insightful. In the next video, we'll delve into the classification, potential complications, and crucial management strategies for acute pancreatitis. Don't forget to like this video, subscribe to the channel, and let me know in the comments if you have any questions.